This is ECG of 30 years old man who complains of rare palpitation attacks. We will examine ECG by the order in the left. And first thing that we need to check is voltage and paper speed. Paper speed is 50 mm per second. It means that one large box is 0.1 second and one small box is 0.02 second. 10 mm is 1 mV. Next step is pacemaker of the heart. For evaluation the pacemaker of the heart, let's find the P wave in second standard lead and AVR. If P wave is located before every QRS complex and it is positive in second standard lead and negative in AVR, this is sinus rhythm. Next step, regularity. For evaluation the regularity, let's check the RR intervals. The first RR interval is equal 6 large boxes and 4 small boxes, or 0.68 second. The next RR interval is equal 12 large boxes and 3.5 small boxes, or 1.27 second. Next RR interval almost equal to the first one. So we have irregular sinus rhythm due to pause episode. Now for differential diagnosis, let's compare the pause duration to two previous RR interval. As you see, our pause is less than two previous RR interval. Now let's play the game. So if the pause is less than two previous RR interval, it can be second degree atrioventricular block type Mobitz 1 or second degree sinoatrial block type Mobitz 1. We have another video about the sinoatrial block, link you can find in description, and also it can be blocked atrial extrasystal. We know that P wave should be present inside the pause in case of AV block and blocked atrial extrasystal, unlike the sinoatrial block where P wave is absent. So the first thing that we need to do is try to find the P wave in the pause. Remember that it can be merged with the T wave of previous complexes, or even can be located inside the previous ST segment. In our example we see the negative P wave just after the T wave of previous complex. If we look closer we can find the P wave in another leads too. So if we have a P wave inside the pause, it can't be sinoatrial block. The next step is evaluate the prematurity of P wave. Remind that in case of second degree AV block, it can be slightly earlier than usual P, but in case of extrasystal, P wave will be truly premature. For this we measure usual PP interval and compare it to our PP interval in the pause. As you see that our P wave is definitely premature. And the last step for confirming the premature origin of P wave is evaluation of P wave morphology. If P wave is negative in third standard lead and AVF, this P wave has lower atria origin. As a result, the second degree AV block is wrong answer. And blocked atrial extrasystal is correct answer. Extrasystolic QRS complex is blocked in AV node due to its refractory period. Consequently, this pause is incomplete compensatory pause. That is criteria of atrial extrasystal. The next step is heart rate. For the calculation of the heart rate, we need 60 divided by the RR interval in second. So the heart rate in first RR interval is 88 beats per minute. Heart rate in the pause is 47 beats per minute. Heart rate in the other RR interval almost the same as in the first one. So we have irregular sinus rhythm by blocked atrial extrasystal. Heart rate is 88. After this, let's check the mean QRS axis. For better view, let's change the voltage from the 10 mm per mV to the 5 mm per mV. For evaluation of the mean QRS axis, we need to find extremity lead with maximal sum of QRS waves amplitude. Usually this is lead with maximal R wave, but let's check. In second standard lead we have maximal R wave and little Q wave, so the sum will be maximal and equal minus Q plus R. As a result, the sum is 15 mm. After this, we need to find the lead with biphasic or near to biphasic complex. In other words, a lead with equal or almost equal Q and R waves. In our case is AVL. After this, we use hexaxial diagram and find the lead with biphasic complex. After this, find the lead with maximal sum of QRS amplitude, which indicates the alpha angle. If your measurement is correct, these two leads should be at right angle to each other, as in our example. Consequently, the alpha angle is plus 60 degree, which indicates normal mean QRS axis. Next step is one-by-one evaluation of all waves and segments. All waves and segments are in normal range, so for saving your time I will add the results of the measurements according to the second standard lead. If you need to detail check, press pause. After this, let's check the R wave progression in chest leads. For more clear evaluation, let's again change the voltage to 5 mm per millivolt. In case of normal R wave progression, R wave amplitude in chest leads should raise from the V1 to V4 with maximal point in V4. R in V5 and V6 should be smaller than in V4. Let's check. V1 has minimal R. R in V2 is bigger than in V1. R in V3 is bigger than in V2. R in V4 is bigger than in V3. Now look, even by eye, R in V5 is bigger than R in V4. Let's check. R in V4 is equal 90 mm. Remind that voltage is 5 mm per millivolt. Whereas R in V5 is 22 mm, that is abnormal. R in V6 is equal 20 mm, that is also bigger than in V4. Therefore, we have example of abnormal R wave progression. That can be signs of left ventricular hypertrophy. For clear confirmation of ACG criteria of left ventricular hypertrophy, let's check the European Society of Cardiology guideline according to the arterial hypertension. Here we have the most commonly used ACG criteria for left ventricular hypertrophy. Now let's check it one by one. Sokolow-Lyon criteria is the sum of S wave amplitude in V1 and R wave amplitude in V5. If it is more than 35 mm, we have positive criteria of left ventricular hypertrophy. S wave amplitude in V1 is equal 14 mm. R wave in V5 is 22 mm. Together is 36 mm. As a result, the Sokolow-Lyon criterion is positive. Next step is evaluation of R wave amplitude in AVL. In our case is equal to mm, so this criteria is negative. Now let's check the Cornell voltage, which means the sum of S wave amplitude in V3 and R wave amplitude in AVL. S wave in V3 is 6 mm. R wave in AVL is 2 mm, so the Cornell voltage is 8 mm. And this criteria is also negative. And the last one is Cornell calculation product. For this we need Cornell voltage multiplied by QRS duration. As a result, Cornell calculation product is equal 640 mm per millisecond, which is not enough, and this criteria is also negative. So from all criteria we have only Sokolow-Lyon as positive. So we add this to our conclusion. But remember, for confirming the left ventricular hypertrophy, you should use echo criteria. Blocked atrial extrasystole does not explain the palpitation attacks. We have some unexpected results of 24-hour ACG monitoring in this case. Let me know in comments if you want to see another video about this. If you like the content, press like, subscribe to our YouTube and Telegram channel, and have a good day.